All right, today we're going to play medical detective. We're cracking a case that almost everyone has dealt with at some point, joint pain. We're going to decode the clues your body is sending out and see exactly how doctors and clinicians solve the mystery of what's really going on. You know the feeling, right? That nagging ache in your knee, maybe a sharp twinge in your shoulder, or that stiffness in the morning that just does not want to go away. Joint pain is, a pretty universal thing, but it's also a really complex puzzle. Every single sensation is a clue, a piece of a much bigger story. Okay, so let's get into it. The very first thing a good clinician does isn't ordering a bunch of tests or an x-ray. Nope, it's to listen. Your joint pain is basically broadcasting a very specific story, and the whole diagnostic process is really about learning how to speak its language. So the investigation always starts by gathering the verbal evidence. Before even touching the joint, a clinician is building a case file, and it's all based on your experience. They do this by asking a really structured set of questions that are designed to nail down the key features of the pain. Every single one of these questions helps to narrow down the suspects. Is the pain just in one joint? That might suggest an injury. Or is it in a lot of joints and symmetrical on both sides of the body? That kind of points towards something like rheumatoid arthritis. Did it pop up suddenly like gout loves to do? Or did it creep in over time? Does resting make it worse? Is there a fever? Each answer is a crucial breadcrumb, pointing the whole investigation in the right direction. So those first few questions, they lead to this huge fork in the road. And it's all about figuring out which of two major categories of joint problems we're dealing with. On one side, you've got inflammatory pain, like with rheumatoid arthritis. The telltale sign here is that it actually gets better with activity, and that morning stiffness can hang around for more than an hour. But on the other side, you've got non-inflammatory or mechanical pain, like an osteoarthritis. For this one, activity makes it worse, and rest is what brings relief. Just by figuring this one thing out, the list of possible culprits gets way shorter. Okay, so the verbal clues are all gathered. Now it's time to collect the physical evidence. The physical exam can really be boiled down to a simple three-step approach. Look, feel, and move. This is where the clinician starts to confirm the story that you've been telling. The physical part of the investigation kicks off with just simple observation. The clinician looks at the joint that's bothering you, and they always compare it to the same joint on the other side of your body. Are they symmetrical? Is there any obvious swelling, redness, or even signs that the muscle around the joint is shrinking, which is called atrophy? All of these are huge visual clues that something's up. Next up is palpation, or feel. This is the hands-on part. By gently touching the joint and the areas around it, a clinician can pick up on the 4 classic signs of inflammation. Swelling, which might feel kind of boggy or like there's extra fluid in there. Warmth, which is actually best checked with the back of the hand. Any redness, and of course, pain or tenderness when they apply a little pressure. And the last step is move, which is all about checking the joint's range of motion. And this is so critical because how a joint is built totally dictates what it can do. Think about it. A ball and socket joint, like your shoulder, it's meant to move all over the place. But a hinge joint, like your elbow, pretty much just bends and straightens. So by testing these movements, both actively, where you move it yourself, and passively, where the clinician moves it for you, they can figure out if it's working the way it's supposed to. But wait, how do they know exactly what's causing the problem with the movement? Well, this is where a really deep understanding of anatomy becomes the clinician's superpower. It lets them connect one specific painful movement to one tiny specific part of your body. This is a perfect example. Shoulder pain is incredibly common, but is it the joint itself? Is it a bursa? A tendon? Who knows? But by having a patient do a very specific movement, like raising their arm out to the side, the clinician is intentionally putting stress on one particular rotator cuff muscle, the supraspinatus. If that exact movement causes the pain, boom, that's a massive clue that the problem is probably with that specific tendon, not necessarily the whole joint. Every special test is designed just like this, to isolate and kind of, interrogate one structure at a time. All right, so the interviews are done. The physical evidence has been collected. Now it is time to put all of those puzzle pieces on the table, look at the patterns, and make that one final critical distinction that's going to crack the case wide open.
So the final step really zooms in on the location. Is the problem articular, meaning it's inside the joint capsule itself? Or is it extra-articular, which means it involves all the stuff around the joint, like tendons and ligaments? The absolute dead giveaway is in the range of motion. See, if a problem is articular, both your active and your passive range of motion will be limited. But if it's extra-articular, like tendonitis, you'll have pain when you try to move it yourself, but your passive range of motion, when the clinician moves it for you, will often be totally normal. That one little finding can pinpoint the exact source of the pain. It's pretty amazing.
So, there you have it. From a simple little ache to a complex diagnosis, it's all a process of listening, observing, and interpreting. The clues are always there, so the next time you feel a twinge or some stiffness, just take a second and think like a detective. What story is your body trying to tell you?